Hello, guys. My name is Jo. I am the newest consultant here. What am I trying to say? Anyway, yes, and I'm giving your first teaching of your rotation of the ones that are new, of the ones that are old. But welcome back. Thank you for listening to me again. Hello. No. Oh, please.
No, you don't have to move. I'm not like a queen or something.
Right, so for some reason, I think it's just been a legacy of years of topics I've accumulated, but I am giving a talk today on endocrine emergencies, even though I'm not an endocrinologist. And it's basically my little log of endocrine cases that I've seen through the years, and me going on about, oh, I wish I knew this earlier, and this is or isn't in the guidelines. So here we go. This is going to be an hour of Jo reflecting on her experiences or lack thereof. If I can move the slide, come on. Yay! So, plan, I am going to talk to you about some cases that I've either seen myself or heard happen close to me. Some pathophysiology. Now, there are varying levels of pathophysiology of this presentation, depending on A, how much I know the pathophysiology. Like I said, I'm not an endocrinologist. And also B, how much I think will be helpful for you to understand how you're treating your patient. So there will be varying levels of detail. Management, which is the important thing, some intensive care quirks. So endocrine emergencies is a medical topic. Okay? However, by the time they present to intensive care, there are usually some quirks. Sometimes we deviate away from guidelines because of extra resources that we have, or sort of some dogmas that intensivists go by. So I'm going to try and unpick some of them, how what we do might compare to what it says in the guidelines. And then also appreciate the complexity of presentations. A thyrotoxic storm in a textbook is not the same as a thyrotoxic storm that you see in real life. So I've got some cases. So I've just listed all 5 cases. We're going to talk through them, and then we're going to go through them condition by condition. Some, the ones that have been here for slightly longer, this one is a very recent gentleman, actually. You may or may not recognise it. 36-year-old gentleman who has a known alcohol excess and known type 1 diabetes, was found at home, collapsed, and vomit all over the floor. Unstable, breathing unstable, circulation unstable, and also up under GCS. Glucose of 20, ketones of 7. So what is an obvious problem here? Just from those two numbers, DKA, endocrine emergencies. We do a gas, pH of 6.7, and a PCO2 is 4. Nervous enough.
Well, you might have something which can pissed off.
No.
Take the light out of that. Check those lots of things. We go.
This is a chest X-ray, which I actually took off the internet rather than the actual patient's X-ray, and there's something I was pointing to the pathology. But what else is on this chest X-ray other than DKA? You can't diagnose.
What's the
Infection, yes. It might help if we turn the lights down.
You have some air in his intestine.
Air mediastinum. So this gentleman also has, as well as vomiters all over the floor, pneumomediastinum on top of his DKA up under GCS and all the rest of it. So there you go, case number 1.
Sorry, where do you see that?
Still, these arrows. Should we turn the lights down? Me pointing is not going to be helpful. So there's the aortic knuckle, and usually that's the only line that you should see. And there are some extra vertical lines there, especially this one, this dark strip here that goes down beyond the cardiac border. That is air where it shouldn't be. So that is air on the mediastinum.
It makes the audience feel better.
That's why there are arrows there. So issues, one of them is DKA. What else? What are the other issues? I'm not asking for answers, just what are the problems here?
Probably not protecting his airway.
Yeah.
Alcohol withdrawal.
Alcohol withdrawal, yeah, that might be why they're low GCS. Why might they have pneumomediastinum?
His esophagus because of vomiting.
Yeah, exactly. So this is DKA and other stuff. To intubate or not?
Consultant was probably right. So one of those that is usually a rocky intubation. It's already
Indeed.
quite chemically deranged, and he already not really compensating a bit for that with his CO2 being at 4. And once you intubate him, you're going to take that away.
Exactly.
CO2 is going to rise, pH is going to get lower, going to cardiac arrest, and then.
You've done my entire presentation. Perfect. So bear all of those things in mind. Next case. Another one in the last, these two cases are both since I started here. It's always been, already been busy. So a 45-year-old lady who presents with hematemesis, long past medical history, diabetes, peripheral vascular disease, already had an amputation on one side, established heart failure. In resus, they were hypotensive, oliguric. I don't know how they, I think she'd probably already been there for 9 hours and she hadn't peed, standard. But she was alert, unrecordable glucose, ketones borderline, hyponatremic, and a lactic acidosis. So the ketones wasn't causing the acidosis. HB of 50 and coagulopathic. That's quite a long issues list, but what are the problems that you see can infer them? Bearing in mind this is endocrine emergencies. HHS, yay! And what are the other issues there? Yeah, and is she hypovolemic just from the HHS or something else?
No anemia.
She's also bleeding.
Patrick as well.
True hyponatremia or false hyponatremia? Ooh. What are the things that you need to do? Fix the HHS.
Fix the bleeding.
Oh, why does it keep doing things that go away? I keep forgetting that this is recorded. I need to be sensitive. Fix the HHS. What else are they here?
Transfuse. Lots of bleeding.
Bleeding. Happy days. You guys are basically doing the rest of my presentation. This is easy. Case 3. Another recent case. 50-year-old presenting complaint was unwell, off legs, with a background of quite severe learning disability, so uncommunicative. History of constipation that transpired later, but presents with abdominal pain, distension, and a known congenital adrenal insufficiency, and then was sort of like referred in a hurry from ACB with sort of just very, very deranged obs, and they couldn't get a cannula in, couldn't give him fluids, couldn't do anything. So he was drowsy, but every time he touched his arm, he pulled his arm away. Sodium of 128, potassium of 3. So what are the issues? Yeah, adrenal crisis. Anything else?
Like disturbances alongside that.
So immediate step, your call, and then Dart team are with you. I'm sat in my office because I refuse to move. What do you need to do? Get a line. Yeah, steroids. Yeah. Good. It's going to be very easy. Case number 4, 30-year-old, day 2 post-thyroidectomy. And they're sort of like doing okay on the ward, and then suddenly they notice that they're sort of like spasming there. And they've got numbness and tingling. Say that again, sorry?
Cytotoxicity. That's too late.
No. Hypoglycemia. Why? Taste. Immediate steps. Replace calcium, because what is the other thing? And investigations, they are right linking. You've got hypocalcemia. What's the immediate history? CG, happy days. Ongoing management, replace the calcium. Final case. 60-year-old presented to the oncology unit with new onset atrial fibrillation, rates 140, pararexial, shortness of breath. Background of metastatic melanoma, and has recently started on one of these newfangled immunotherapy agents, something mad. I considered writing it on there, and then I assumed that it would mean the same to you as what it means to me, which is a mab. So I just thought I'd just write immunotherapy and say it's mab. They've recently been started on a mab. So what are your differentials for this person? Tumor lysis for metastatic melanoma? That's like that's a big one, isn't it? Except immunotherapy doesn't usually cause neutropenia. Anything else? So it could still be sepsis.
Yes, yeah, just a good sepsis, which was plainly
Thyroid issue.
Thyroid issue. Investigations?
Yeah, I think so.
So your inflammatory markers are normal, and there are the thyroid numbers. Ongoing management of thyroid toxic stuff. So we've basically done the entire presentation. Now I need to like wrap this up another 45 minutes. So these are the 5 conditions that I'm going to cover, loosely inspired by what I've seen recently, but also there is so if you type in endocrine emergencies into Google, there is the Endocrine Society have written sort of like a to-do guide for common endocrine emergencies, and these cover most of them. There's some other ones on there, but I thought we can't talk about conditions. So these are my 5 chosen conditions to talk about in various amounts of detail. So number 1 is hypoglycemic emergencies. These are the most common ones I've seen. So you've probably seen a lot of this already, and I also realize we've got a varying experience in the room. So bear with me, I'm going to try and pitch it somewhere in the middle and maybe fill in a few gaps for people who have not gaps. If you've been around in ICU long enough, you will know some of the bugbears. If I can answer some of those bugbear questions, then that'll be great. So for those of you that are studying for exams and need to learn and regurgitate definitions, here are some definitions. What is diabetic ketoacidosis? Cornerstones are hypoglycemia and ketoacidosis, and the pathology, and this pathology is what defines it from HHS, is insulin deficiency and the catabolic response. HHS is not insulin deficiency, DKA is. Insulin deficiency is the beginning of everything. In contrast, hyperosmolar hypoglycemic state is usually a stress response which causes hypoglycemia, and then you've got this sort of like vicious circle of the homeostatic consequences of hypoglycemia. So you've got lots of fluid shifts, which then causes sort of electrolyte loss, fluid loss, and profound dehydration. And there is usually, well, even more so than DKA, an underlying stressor. And because of the population that have these, they're much more frailer people, and therefore this vicious cycle sort of manifests a lot more as hemodynamic instability. And because this sort of insulin deficiency isn't technically by textbook the underlying pathology, the definition says that there's not significant, but there isn't significant ketoacidosis. But I have seen many people with ketones of 3 or 4 who I will treat them as HHS because if they're sick enough, they will have a ketosis anyway, even if the fundamental pathology isn't insulin deficiency in the same way type 1 diabetic does, if that makes sense. Fine differences. I've put in just a little slide here. I think the awareness for euglycemic ketoacidosis is now a lot more. I think many years ago, before we started very commonly using the SGL2 inhibitors, that is the dapagliflozin, MPAT, I still can't say it, the flozins, or the flozins. Now that we use them more and more, we are seeing euglycemic ketoacidosis a lot more. So this is just a little slide. You can have ketosis without a high PM. So if your patient is acidotic, even if their glucose isn't high, it's always worth checking. Because ketones are easily fixable. It's an easy win for your patient with acidosis that you don't want to miss an easy to fix ketosis. Apart from the flozins, starvation, alcohol, again, we see increasingly common because of our complex sort of patient population. Sepsis, liver disease, adrenal insufficiency, pregnancy. Just check ketones. If your patient is acidosis, check the ketones. This is lifted straight out of a textbook. It's literally a column by column. Sort of, if you look at your gas, you can compare it to this table and diagnose your patient with one of these conditions. But as I've said on a previous slide, you can call it DKA, you can call it HHS, you can call it whatever you like. The treatment is largely the same, so I'm going to slip over this one. But by and large, actually, the significance of this is that if you are being referred from A&E, from the medics, they will be using this table to sort of triage their calls to you. And if you've taken enough referrals, you will know that actually these numbers aren't necessarily how you would stratify as the ITU reviewing person. These numbers aren't the ones that you use to stratify the risk of your patient. You use a lot of information, but understand that stressed medical SHO or that stressed A&E person who's calling you is using these criteria. Omar is like, yes.
Yeah, I've been in research multiple times.
Exactly.
So I was like, we need to call ITU.
Yeah, you're bound by these numbers. But as the ITU person taking the referrals, you can use these numbers, but actually you need a lot more other information to stratify risk. A little formula at the bottom for calculated plasma osmolality is directed at those who are advising for FSCA or FICM or any other exam that requires you to talk about plasma osmolality. Pathophysiology of DKA. I remember when I made this slide many years ago, I made it mainly for my own benefit because I just couldn't, it was me. Just didn't understand how diabetes itself can cause such a profound derangement of physiology. As I mentioned a while ago, it all starts from insulin deficiency, which pushes the body into starvation. And it is the starvation. And why do they get dehydrated? That's also what I think. So insulin deficiency, there's lots of words there. The ones in bold are the ones that are important to me. So the insulin deficiency causes a stress response. And then basically, because the body doesn't have insulin to take the glucose into the cells, you've got glucose swirling around in your plasma, which isn't being used. Your body then starts breaking down other fats and amino acids. So at least you don't starve. The hyperglycemia, the glucose that is swirling around in your plasma, causes an osmotic diuresis. And for me, that satisfied me that is where the dehydration comes from. You just peeing out all the volume, hence the polyuria in newly diagnosed diabetics. And then the stress response from breaking down your proteins and your fats is what gives you your ketosis. They're literally the breakdown products. That's what gives you your acidosis. And that catabolic response is what pushes your body into that sort of like deranged state. So an osmotic diuresis, an inability to process insulin, which causes your electrolyte imbalance. Random MCQ fact, I pondered whether I should keep this slide in. And I decided to keep it in for two reasons. Number one, anyone who is studying for FRCA, I think this comes up as an SVA at some point, there are 3 types of ketones. But why do I still think it's important? If you are treating someone with DKA, you are measuring the ketones and they will say you need to keep treating for DKA until the ketones are less than 0.3. The reason being, out of the 3 ketones that are generated by the body, only one of them is being measured. So actually, even if you've got a measured level of 0.3, your actual ketones level is higher. So keep treating them until it's really low. Then your actual ketone level and your actual ketosis has actually been switched on. So there you go. There's sometimes some relevance to these random recipe facts. Pathophysiology of have I written HSS there? I thought I changed it. Damn it. Pathophysiology of HHS, how does it differ from DKA? I mentioned briefly earlier that DKA is a state of insulin deficiency, glucose swirling around the body, and the body not using glucose. HHS is similar to that, but because of the higher level of glucose, the fluid shifts is more pronounced, the catabolic effect is less pronounced. So it's more about the hyperosmolality, more about fluid shifts. That is a lot of words to say exactly what I just said. Fluid shifts, electrolyte disturbances. This is the DKA slide repeated. And this is the modification between, from my understanding, that the differences between DKA and HHS. So the more pronounced hyperglycemia, more pronounced hyperosmolality, hence more osmotic diuresis and more electrolyte imbalance, which is why when you are treating someone which HHS, not HSS, HHS, there is even more of an emphasis on fluid replacement, but we will run into problems which we will talk about when we go back to our 2 cases. That was my talk on my rambling talk about pathophysiology, and then we need to talk about the management. What are you going to do when you go to research or you go to ACB to see these patients? Management of anything. Anyone who's still got exams to sit, you are asked to do a case that describe how you're going to manage a case, recognise the emergency, call for help, A, B, C, D, E, assess and resuscitate as I proceed. Everyone is very good at this. And they all do their, I will assess the airway, I will shoot their circulation. One thing that I normally encourage anyone who practices exams with me is once you've done your A to E spiel, don't forget, and people are very well rehearsed in this, don't forget to recognise and treat the underlying condition in the question that you're being asked. The get out being that if you don't remember the specifics, you can always say, I will follow the trust policy for DKA, for HHS, for thyroid toxicosis. So there you go. There are 6 points to get through any exam question. Can you tell I wrote this presentation when I was preparing for exams? And it's like even lingered through. Treatment of DKA. That is a QR code leading to the actual most recent guidelines, which I think is in 2023. And you can try, and there's like 4 pages long, and there's like tables and graphs and all sorts of things, but I always remember it as 4 things. If I see a patient with DKA, I think I need to do 4 things. Number 1, and the most important one, precipitating cause, because otherwise I'll just keep getting sicker. Usually it's antibiotics or some sort of infection. Restore the circulating volume, and you may or may not have the experience. DKA patients tend to be young, they tend to be the type 1 diabetics, they tolerate fluids very well, by and large. And these are the ones, when you go and review the DKAs, they might have extremely deranged gases. But if you think that they can tolerate the fluid load, where would you risk stratifying these patients as the ITU reviewing person? High risk or low risk, if they can tolerate fluid resuscitation.
Tend to turn out quite quickly, though.
Exactly.
You get a horrendous gas and suddenly turn the light through.
Exactly. And we're going to come back to that horrendous gas in a bit. Correct electrolyte disturbances, and actually, and particularly in children, the mortality from DKA doesn't tend to be the DKA itself. It tends to be not managing the electrolytes properly. And actually, probably the patients that we do admit with DKAs, even the ones that can tolerate fluid loads, are the ones that have fallen behind on their electrolyte replacement, and now they've got a potassium of 2, and you're like, well, now you're trapped. So make sure you correct the electrolyte disturbances and suppress ketogenesis. So if the problem is insulin deficiency, you need to give them insulin. I've got a few slides now which are lifted straight out of the guidelines. They're really, really dry, so I'm going to go through them moderately quickly. And these are lifted from the endocrine guidelines. So these are probably what is translated into trust policies. Heavy emphasis on normal saline, heavy emphasis on replacing potassium preemptively, because actually a lot of the mortality of DKA is from not replacing potassium sufficiently. Insulin, and we would normally prescribe a dose of 0.1 units per kilogram per hour, so 6 or 7 units per hour for an average person. Continue any basal insulin, so that's a very, very important one. And then the other cause of mortality is hypoglycemia for what the over-enthusiastic insulin administration with the other cannula that's kicked in. We're not giving them the glucose. So make sure you replace potassium and replace the glucose when you need to. And there are some targets lifted straight out of the guidelines. And there you go. Treat until the ketones are less than 0.3, bearing in mind that your ketones are not actually 0.3 when you made them 0.3, or until their acidosis is better. Like I said, find and treat the precipitating cause. These are very, very dry. And coming to the end of your DKA treatment, how do you sort of like transition from that urgent DKA treatment to a sliding scale? Sliding scale if you're not eating or drinking, and make sure you sort of transition. So stop the sliding scale. We, I think, typically said half an hour after you've given them a normal subcut dose. This is all lifted straight out of the guidelines. More relevant and more about Jo talking about her experiences. How is DKA treated differently on ICU? So hands up if you haven't looked after someone with DKA on ICU and we haven't followed the DKA protocol.
Yeah,
Hey! And why? Yay! Yes, as well. So why don't we follow the DKA protocol on ICU? Because we're naughty, because we can get away with it, and because we can monitor. So the DKA protocol, as recommended by the endocrinologists, are very, very largely very safe. They are focused around potassium replacement, glucose replacement, and giving lots of fluid. And what is mainly the main way of replacing potassium on the ward?
Sodium chloride with some potassium in it.
Exactly. And then you come to ICU, and then lots of people will tell you that normal sodium chloride, normal saline is the devil. And what is the problem with normal saline? I've heard it's acidosis.
You can get a hypochloremic acidosis.
Yes, hypochloremic acidosis. So the problem when you give lots and lots of sodium chloride, as dictated by the endocrinology guidelines, the problem with a high chloride load is hypochloremic acidosis. This is something else that took me years and years to understand, so I'm going to explain it just in case anyone else is struggling like I was. You do not want to be a battery. You've got cells and you've got plasma. And your cells and your plasma basically have to be electrically neutral. So if you give lots and lots of chloride to the plasma, then yeah, if you give lots of chloride intravenously, basically all the bicarb in your plasma has to go into your cells. Otherwise, your plasma becomes electrically charged. So if you're actually losing bicarb into your intracellular, chloride in your plasma actually makes you acidotic rather than helping you cure your ketoacidosis. So sure, your ketones are going down, but your chloride is going up, your bicarb has gone down, so you actually become acidotic. Will you believe it? It took me about 3 or 4 years to sort of like figure that out. It was until someone said your cell doesn't want to be a battery, and I was like, oh. So there you go. Look, it took me a long time to get it. So there you go. That is why normal, so that's why sodium chloride 0.9% is the devil, because of the high chloride load. So what you'll find on ICU is that we don't use that. And the other benefit of how else can we replace potassium on ICU? Centrally, which comes with a much less fluid load and a much less fluoride load. So if we can, and we still need to replace the fluids because the fluid loss is still an issue. So we can replace potassium centrally and give Hartmann's instead, which comes with much lower sodium, much lower chloride load, and therefore potential quicker resolution of acidosis because you're fixing the ketosis and you're not giving them massive chloride load. The question is the acidosis actually a problem? And we'll come and talk about that shortly. Intubation. So the question that I asked with that 36-year-old is when and why would you intubate a patient? Omar, you said there was a big problem with intubating these patients. What is the problem with intubating what group of patients, even if they were a bit obtunded, what marker would you use to say, actually, I'm not going to intubate you, even though your GCS is 7? What's the one number that you look at? I know what's the number that I look at.
I think you're going for CO2.
Yeah, exactly. So there's something called the Boston rule, where there's a YouTube video on the internet somewhere. But basically the idea is that usually, and especially the young fit ones, when they're acidotic, they compensate extremely well and they will hyperventilate. You'll do a VBG and their PCO2 will be like 3 on the VBG. So you know if you do an ABG, their PCO2 will be 1. Because they are taking such massive tidal volumes that if you decided, oh, their GCS is 7, I'm going to intubate them to protect their airway. Actually, can you replicate that minute volume with your World circuit? Probably not. So the DKAs, especially if they're alert, especially if their GCS is fine, if their PCO2 is 1 on their ABG or 3 on their DBG, you do not want to touch them. Even the really quite obtunded ones, if their CO2 is low, you're probably better off leaving them, treating them as DKA, and they will wake up. And I've seen that more than once. They literally look dead, but you just fix the acidosis. They will get better. The Boston rule. There is a YouTube video talking about PCO2 plus bicarb minus this minus that. I don't like formulas. I go by feel. If the PCO2 is low, then don't intubate them. Probably be okay. What was the problem with that 36-year-old?
Everything's media standard as well.
Yeah, and the media standard, what was their PCO2?
4.
Exactly. Is that good or bad? For someone who's so acidotic, for a 36-year-old who
Not compensating.
exactly failure of decompensation. So usually you wouldn't intubate someone because their CO2 is 4, but similar to an asthma sort of type patient, if their CO2 is 4 with a pH of 6.7, they're probably not going to do. That dude got intubated. Another thing that you will see, and now I'm not saying that this is the right thing, using bicarb. The coffee is made. Does anyone want coffee? Please get coffee. Coffee. Using bicarb. So I don't know if I didn't intubate that man, someone else did. But as Omar said at the beginning, when someone already has a pH of 6.7, their PCO2 is 4. But if you give them an anaesthetic, you don't ventilate them for a minute, and their CO2 will rise even more. Before you know it, their pH will be 6.5. And then you risk, inverted commas, this cardiovascular collapse because of the acidosis. That is a very, very loaded statement. So some people, I probably would. I think it would take a very brave person to intubate someone with a pH of 6.7 without some bicarb running in the background to make them feel better. who agrees with me? Who, if someone had a pH of 6.7 would give BiCARB. Yeah, no. So thinking, oh, I think Ravi either isn't listening or wouldn't give BiCARB. Would you give BiCARB to someone to intubate someone with a pH of 6.7?
Yeah.
There you go.
Have lots of fluid running and lots of pairs of hands going.
Lots of pen and lots of base classes and all the rest of it.
Well into boots.
However, that's big. I'm going to open a can of worms as my last statement on the hyperglycemic section. Acidosis versus cardiac contractility. Has anyone seen someone with a pH of 6.7, 6.8 who is a well DKA and their blood pressure is fine, their heart rate is fine, they're perfusing their brain, they're perfusing their kidneys?
Yeah.
Yeah.
Yes.
So by that logic, does acidosis itself cause reduced cardiac contractility?
No.
No. So actually, if does in that context, I'm just challenging the thinking, and I don't think there is a right answer. How true is it that if you run BiCARB for someone who you're about to intubate with a pH of 6.7, how much is that BiCARB actually going to prevent you from cardiovascular collapse?
I think the question that comes to my mind is just not only the cardiac contractility, but because of the medication that we're going to use are designed to work in a pH which is close to the normal pH. And my worry is all my respiratory medication and my induction medication, there are systems that I know more pharmacology more than me. I think that's the other reason that you try to aim to be closer to a normal pH, besides the cardiac contractility and the effects of the acidosis on your cardiovascular system.
I'm going to come back to you again. So you're going to give adrenaline or you're going to give NORAD. A patient who has a pH of 6.7, 6.8 DKA, they have a circulating level of NORAD and adrenaline. It works because their blood pressure is fine, their heart rate is fine. I don't have an answer. I'm just challenging your thinking. I am still going to give BiCARB advantage. Because when they kill out, I'll be like, oh, thank goodness I had BiCARB running. Otherwise, I'd feel really stupid.
But I don't think the acidosis by itself actually has any immediate detrimental effect on contractility. It actually has the opposite effect. But for how long that opposite effect lasts, in the face of you giving some sedative agents to intubate, that's probably where it can change.
Yeah. I think
That's what I think.
and then in terms of the environment where your drugs are working. Yeah, no, I think that's fair.
But also you've got all your other detrimental impacts on acidosis. So that's your other homeostatic mechanisms and oxygen carriage, and all of your tissues will be becoming hypoxic because you will be able to carry less oxygen because preferentially offloads in the situation of acidosis. So you'll be binding less because blood chemistry is loading.
And plus, I've managed to divert an endocrine presentation into my more comfortable zone of just physiology, acidosis of blood. However, I must come back to endocrine because that's where I come with that. And I told you it was a can of worms. More questions after the presentation. A DKA in children, again, I've left these slides in since my sort of like exam era, but so all the problems that I said about sort of mortality in treating back to DKA, treating DKA is electrolyte problems and fluid problems, and children are especially susceptible to this. Especially they are susceptible to hyponatremia, hypoosmolality, because their blood-brain barrier, they just get cerebral edema, not easier. These are exam facts, but basically the principle is don't fluid overload children, and if they start getting drowsy, treat them for cerebral edema and give them hepatitis say. I'm going to skip over that very quickly because these are legacy slides. I'm very happy to share them if anyone wants them. Euglycemic ketoacidosis I've already talked about. Going back to the case, I think we've exhausted it now, haven't we? Issues that we've talked about. So this dude who's collapsed with vomit, issues, DKA, possible esophageal rupture, obtunded GCS, and also failure of respiratory compensation. What would you do? So this man got tubed, he got treated really aggressively with the DKA protocol, and actually, because his DKA was so profound, he did then develop hypochloremic acidosis. So he got switched to the whole Hartman's central potassium business. He was intubated and he was also treated with, oh, there we go. Oh, I've written the answers. I didn't need to memorize it. So on top of all of that, he also got a PICC line and he got treated, he got TPN while waiting to see if the bore halves was actually a real thing. And actually a couple of days later, he got a CT, which showed that the immediately sound had gone away. It probably was like a rupture of the pleural leg rather than his esophagus. So he went back to engine feeding. And then he got better after a while. Gosh, am I still talking about hypoglycemia? I think I need to speed up a bit. Although a lot of this is compared to spot the difference. So management of HHS, I've corrected it here, it's HHS, not HSS. As we've alluded to a few times, the difference in HHS between DKA, or the emphasis is, number one, the more frail patient population. So someone who is referred for HHS, I will usually have a much higher risk awareness than someone with DKA. Because they don't respond as beautifully. DKA, by and large, if you follow those guidelines, they will respond, as you said, and they will get better as long as they can tolerate the fluid load. HHS, the pathology is fluid shift. The problem is, even though they've lost a load of fluid, they don't tolerate the fluid replacement well because of other underlying comorbidities. Having said that, here is me lifting the guidelines out of the guidelines into slide form. Again, because they are designed for use on general wards, it is heavy emphasis on sodium chloride, and we're aiming for a positive balance because there is a unmeasurable negative balance from that osmotic diuresis that we talked about. There is an emphasis on sort of continuously measuring, or not measuring, calculating the plasma osmolality, because you don't want big shifts, because that's what causes shifts across the cells, cellular edema, and that's how you get neurological dysfunction. This bit is about management of insulin and HHS. Now, remember, I mentioned at the very beginning the difference between DKA and HHS. The insulin deficiency in HHS is much to a lesser degree. So they say that you should only give insulin if ketones is more than 1, or when the glucose no longer falls with fluids. I am guilty, and I'm going to ask for a show of hands that if someone with HHS is quite acidotic and they're quite unwell, I will probably put up insulin infusion before, before the guidelines. I don't know if anyone's doing it. There we go. Usually because I'm impatient and I just want those numbers to get better. There is the formula again for calculated plasma osmolality, sodium, potassium, glucose, urea, because they are the osmolytes in the blood. Now, hyponatremia in HHS, and I asked the question, is it real or not? Jenny. I think you sort of like gave me a little knowing look. What thoughts do you have on the realness of a measured hyponatremia?
So it can be affected by other electrolytes in the blood, especially in a situation like that where it's very much in flux. On the spot, that's probably as much as I can say other than the nature of your question, expecting me to say
It's sort of trick. There's that sort of trick. So yes, so my caveat for measuring and interpreting sodium in someone with HHS is that if you have a very, very high glucose level in your blood, those machines will, there's something called pseudo-hyponatremia. So the pathology is that they lose a lot of fluid, they lose a lot of sodium. So the sodium level itself cannot really tell you the fluid status because they're just losing both in their wee. But also because the machines are measuring the glucose, I think the compartment of the plasma that they measure the sodium is lower, so you get a false hyponatremia. So basically the sodium reader becomes unreliable, and if you are lucky enough to have a lab that will give it to you, measure, actually send and ask for an actual measured serum osmolality to actually titrate how much you are changing your osmolality. Having said that, that's a very sort of idealized situation. I don't think I've ever actually asked for a measured osmolality in plasma and actually got it back in a time that was useful. And realistically, I would just treat them and make sure that none of the numbers change too quickly. There you go, real life. But just be wary of that sodium level. It's probably not a real number and does not tell you about the fluid status. Complications, I've said this multiple times already. HHS, the problem is fluid and electrolyte flux. I've written this because I have seen one case where the patient has central pontine myelinolysis before we even got to them, because Remember, central pontine myelolysis is usually what we talk about when we treat someone with hyponatremia too quickly, and you give them a hypertonic insult by giving them too many hypertonic saline, and basically they get a fluid shift. And you give them cellular edema and they get central pontine. It's very more complex. I have seen a case where actually I think the patient had been in HHS so long and so was so hypotensive that actually they came in with a generalized weakness, and that was actually they had an MRI that actually showed that they had central pontine myelolysis, which they gave themselves by being in HHS. Want to avoid a rapid fall, so don't give them dexaline, because if their plasma osmolality is 310 and you're giving them fluids of 125 or you will cause fluid shift in the other direction, and you'll get cellular edema, brain and lungs, get cerebral edema and pulmonary edema. We talked about this already. Look and treat for the underlying cause. So going back to this 45-year-old lady who we saw. Issues. So she had all of these problems. She was bleeding, she was coagulopathic. We've talked about these already, haven't we? So what to do about it? So this lady, she got treated. There was a delayed recognition, I think, that there was HHS and the amount of fluid deficit that she was fighting. So she was transfused. So she was very hypotensive. I think her blood pressure was like 60/40 after like 4 or 5 units of fluids. I think what wasn't recognised is the actual sort of like free fluid deficit that she was in as well. So actually, once she got some fluids and got some, did she get insulin? I don't remember. Her blood pressure actually genuinely got better. And because she was so frail, and this is another thing, these patients, they are frail, they are unable to deal with the fluid load. So she got a bit of vasopressor as well. And then the other thing with this lady, so she was bleeding, she got her coagulation factors. She also had a hiding necrotic toe somewhere, and she also had a hiding vulval abscess, which wasn't found until a little bit later. And actually, it was once we sort of found, so she got treated, all of the blood and the coagulation issues. She got her fluid, we found the abscesses, and then she slowly got better and then had a purple form and left ICU and never came back. Did I say that out loud? Right, case number 3. We're doing all right for time. We're going back to our young gentleman with the learning disabilities, known for genital adrenal insufficiency, and they were having an adrenal crisis. So, adrenal insufficiency, textbook stuff. 2 types of adrenal insufficiency, primary and secondary. This gentleman had primary adrenal insufficiency, and it was congenital in his case as part of his learning disability syndrome. But remember that there are other rarer causes of primary adrenal insufficiency, TB, tumour, bleeding. And the ones with the primary adrenal insufficiency, they tend to lose their mineralocorticoid as well. And that is important in how they are treated long term and how we treat them in acute phase. Secondary is probably what we see and try to prevent a lot more. And the most common one we see is exogenous steroid treatment. And this one is asked time and time again, so I've written it in bold. Anyone who has recently had 4 weeks or more of 5 milligrams of just 5 milligrams of what? Need to change this. 5 milligrams of prednisolone or equivalent per day of steroids, they are at risk of adrenal insufficiency if they have a stress event. And what is the pathophysiology? What is the problem when you lose or you have insufficient cortisol or response to cortisol? So, quick reminder, cortisol is what is needed for actually NORAD and all your system needs a baseline level of cortisol. So if you have not enough cortisol in your body, you can give all the NORAD and you give all the adrenaline that you want. Those receptors will not work. You won't be hypertensive. Steroids are also responsible for sodium retention in the kidney. So if you don't have enough cortisol, you will lose your sodium and you will lose your water. So if you have an adrenal crisis, you have hypotension because of fluid loss and electrolyte loss, and you have hypotension because of loss of beta glutathione. Those are the 2 main things. Yeah, I don't know how to organise this slide. This slide is sort of clues. And so this gentleman, the gentleman in the case, came with a label. He said, "Hello, I have congenital adrenal insufficiency and I'm ill, please treat me." And you're like, well, this is obvious, let's give you some hydrocortisone. They don't always come back clearly, but if they have this sort of like vague history of lethargy, weight loss, dark skin, if it's pituitary disease, I will go through the pituitary as they wants me to, basically dark skin, think about pituitary disease. These are the other features that would suggest that actually has this person been building up to adrenal insufficiency. Certain drugs, azoles, fluconazole, St. John of Wort, can cause an adrenal insufficiency. And they can be grumbling along with this adrenal insufficiency, and then they get a stress event, complete inability to cope, and that's when they come in an adrenal crisis, which is usually where we get involved. And they will have hypertension, electrolyte derangement. Management priorities. So the immediate thing to do for anyone with an adrenal crisis is 100 milligrams of hydrocortisone, water, or 5% glucose, as I used to do. Give it, and then a 200 milligrams per day infusion, sort of almost regardless of their baseline dose, because there is very low risk associated with short-term sort of cortisol replacement. So if in doubt, just do it. Fluid resuscitation and electrolytes, treat the numbers in front of you. Acknowledge, similar to DKA and HHS actually, that there is an unmeasured fluid loss. Just because even if they don't have diarrhea and vomiting, there will be some degree of unregulated renal fluid loss. So treat the fluid deficit. For a newly diagnosed primary adrenal insufficiency, that is someone who has lost both layers, so they're not making cortisol, they're not making aldosterone, they will be treated with fludrocortisone. If someone has established primary adrenal insufficiency, as our chap does, he was usually on hydrocortisone, usually on fludrocortisone. If you supplement the hydrocortisone, I learned this, you do not need to give them extra fludrocortisone, because the hydrocortisone has enough mineralocorticoid activity, especially if you give them 200 milligrams, to account for the fludrocortisone. So the only thing you need to worry about is hydrocortisone. If it's a new diagnosis, and this is sort of all very medical, I used to understand this a bit better. If you check around, this is easy to understand. Check a random cortisol, and there's two extremes. If random cortisol, not a morning one, if their random cortisol is more than 500, then it's probably not an adrenal crisis. If it's less than 100, regardless of time of day, then it's confirmatory. If it's somewhere in between, if you're doing it in the afternoon, then it's unhelpful. And you can do, when everything is in control, a short sign-acting test. You give them a dose of ACTH, the pituitary hormone, in the morning, and you measure their cortisol response, and you're literally saying, does your adrenal gland respond to ACTH? Or do you have an intact hypothalamus pituitary axis? That's a little bit further down the line. I don't think I've looked after a patient long enough on here to get around to doing a short sign-acting test. When I did medicine, I did lots of these. But on here, less so, because they're usually too sick to get a reliable result. I've put this slide in because I think it is important for general awareness, prevention of adrenal crisis. So patients who are steroid dependent, they have sick day rules. So they should be educated by their endocrinologists how to prevent adrenal crisis. And probably as clinicians, especially if we go to the front door a lot, A&E in medicine, and sort of like in ITU, when you're taking a blood history from a patient, have they been following the sick day rules? Patients who are on hydrocortisone, they should know that if they have any sort of stress, diarrhea, vomiting, apparently, even if they have a family bereavement and they're like emotionally stressed, they are told to double their hydrocortisone dose, just double, not 200. And they should double it for 48 hours at least, and then just carry on until their stressor is better. And if their stressor doesn't get better, then they should go to hospital. And I think this is relevant for us at the front door, because if they haven't been following the sick day rules, someone comes in with a card saying, I have adrenal insufficiency, I've been vomiting, I've not been keeping down my oral hydrocortisone, they are already 48 hours behind by the time you see them. High risk stratification. This is for the anaesthetist, because this is revision for me. If your patient has secondary adrenal insufficiency, that is, they don't have an aldosterone problem, dexamethasone is okay for 24 hours because they have enough aldosterone. But if they have primary insufficiency, that is, they don't make aldosterone, they don't make cortisol, then give them a proper dose of hydrocortisone. Don't think you'll get away with just giving them 6.6 of dexamethasone. Then they get the 200 of hydrocortisone until they're able to take their oral dose, at which point they take double whatever their red dose or whatever their dose is for 48 hours up to a week if they're not recovering well after their surgery. And we see these a lot with our inflammatory bowel disease patients that actually land on here after their major sort of like subtotal colectomy, and we're having to titrate their hydrocortisone. Have we covered everything? Issue. So what on this gentleman, this young gentleman, learning disability, adrenal insufficiency, primary adrenal insufficiency. So his issues. Adrenal crisis, we're replacing fluids, always, so immediate steps, he got some hydrocortisone, he got lots and lots of fluid, and he also got vasopressors because he was quite sleepy, because he was really, even with fluids, his blood pressure wasn't coming up. He had abdo pain and bowels not open. This is sort of like a broadening out thing. Patients who have learning disabilities will not tell you if they're in pain. He had a distended abdomen. He was off his baseline in terms of communication. So actually another priority was him was actually, it was a adrenaline bolus running through the CT because we needed to know actually, does he have a major abdominal thing that we need to treat? Because you can give him hydrocortisone all you like, but actually if he's perfect something, then nothing's going to help this guy. We needed that scan to talk to the family. Actually, he is this level of disabled, he is this level of sick. If he needs a laparotomy, yay, nay. If he doesn't need a laparotomy, then what do you do? So that was Alan was the one that I sent down with a syringe of adrenaline going, that CT needs to happen, go, 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 go. She did not thank me for it. And then it was a pressured central line once he landed on the unit. So to get that NORAD more fluids, more electric. Follow up. This gentleman, I hope he got referred to an endocrine, because for someone as complicated as this, I probably would want an endocrinologist to titrate that hydrocortisone back down to his baseline.
You find that or if he was slightly hypokalemic, do you find they go hyperkalemia because of the mineralocorticoid loss?
So
the potassium retention from the loss of that, or just because they're so dry?
So exactly. So I think that's a textbook thing, isn't it? So
yeah.
Textbook is if they have a metabolic deficiency, they don't excrete potassium. Yeah. He was constipated actually. He just thirst-based a load of fluid into his abdomen. So he happened to be hypokalemic. And that's one of the points that I'm trying to make with Joe's law, the textbooks, that they have that. Well, actually, what you see doesn't match. This one's a straightforward one, I promise. And only because I saw a few of these and I was just like, fine, we'll put this out. 30-year-old post-thyroidectomy, and we've already talked about this, haven't we? The parathyroids have accidentally been taken out and they are now unable to produce PTH, unable to mobilize calcium from their gut and bone store, so they are just hypocalcemic. Very classically, this poor lady was just sitting there with her hands like this. So diagnosis is hypocalcemia, immediate steps, replace calcium. Investigations, calcium. Ongoing management, calcium. I told you this one was straightforward. And vitamin D. So actually the long-term management for these patients is vitamin D. So differential diagnosis for an acute symptomatic hypocalcemia. Post-thyroidectomy and post-thyroidectomy are probably the most common ones that we see in this, sort of a very, very acute hypocalcemia, just because they've suddenly lost their parathyroids. I've written a few extra ones on there because we do see them, and actually as ICU we have to decide what to do about them. How have I done this? We'll come back to pancreatitis and rhabdomyolysis. I'm going to highlight them because we're going to come back to them too. Even though it's not endocrine related. I keep getting sidetracked. Features, again, these are lifted straight out of the book. How does hypocalcemia present? Investigations. So I have highlighted this, the difference between adjusted serum and ionized, adjusted serum calcium and ionized calcium for our newer colleagues. You will see that as on ICU and in anaesthetics, we are very, very sort of fixed. I don't remember the last time I wanted to know about the calcium and went to look at the bloods and looked at the adjusted calcium. For us, the calcium that matters is the ionized calcium. So a blood gas measures just calcium ions floating around in the plasma, whereas when we send the blood off to the labs, they measure all the calcium in the blood, which also includes the calcium that is in the protein. So your serum calcium tends to be doubled your free ionized calcium, which is what you get. And your immediately important calcium for clotting, for arrhythmias, is your free ionized calcium. So most of the time, if I have an unwell patient, I just want to leave calcium. So that's why I highlighted for our unicode. Investigations for anyone who has hypocalcemia includes PTH, magnesium, and vitamin D. Very medical. As we said, management of calcium low calcium is give calcium. For anyone that isn't aware, calcium chloride contains about 3 times the amount of calcium as gluconate. Different guidelines will say different things, but know that if you give gluconate, it will take 3 times longer to get to your target level. So either give 3 times the amount or check it more frequently. For this case, this lady who's just lost her parathyroids, she required bolus and then infusion as well because her body was just not mobilizing calcium at all. Completely lost her homeostasis. She had ECG or symptom monitoring on the ITU because she kept twitching every time the calcium went down again. And then the endocrine sort of like guidelines, there is like a step-by-step how to up-titrate your vitamin D supplementation to get them onto something that's a bit sustainable, because you do want to go home eventually after having the thyroid taken out. Otherwise, completely well, like there was nothing else wrong with her. So, causing of rhabdomyolysis and pancreatitis, sidestep from endocrine. Hypocalcemia when you have a parathyroid deficiency is physiological, I want to say, and you can easily fix it by replacing the problem. Hypocalcemia and rhabdomyolysis and pancreatitis are part of the pathological process. So pancreatitis, the calcium is basically not entirely, but like spilled out by the pancreas, and then calcium is part of the pathophysiology in the pancreas cells, releasing them and worsening the pancreatitis. And then it's also precipitated by the whole digestive process. So there is evidence to suggest that actually if you just keep replacing calcium in someone with pancreatitis with hypocalcemia, actually you're not helping them and you're just fueling the pancreatitis process. Similarly, in rhabdomyolysis, if they are breaking down their muscle cells and they're losing their calcium from precipitation, if you just keep giving them calcium, they'll just keep it. So for management of hypocalcemia in these 2 group of patients, I would anecdotally advocate not just measuring their free ionized calcium, but actually keep doing ECGs and check their QTC. If their QTC is okay, then actually hold fire. If you give them calcium, you might worsen the pathology. This one is simple. Last case, I'm running slightly over time, so we'll fifth case, fifth and last case. Do we remember our 60-year-old with melanoma with a MAB, who's received a MAB for melanoma? AF, pyrexia, respiratory distress. Luke, you mentioned thyroid. What made you mention that, or was it just because it was an endocrine emergency that we thought thyroid had to come in there somewhere? Yeah, so immunotherapy are great. There's so many more immunotherapies these days for different kinds of cancers, but I think what we're seeing increasingly in ICU is that they just cause various itis syndromes. It's just inflammation of anything and everything. And one of them is that they can cause thyroiditis and therefore thyroid toxicosis in patients who don't previously have thyroid problem, but they receive an immunotherapy for their cancer and then they come in with itises, and this patient had a thyroiditis. So what is a thyroid toxicosis crisis? So why do I write sentences that don't make sense? The thyroid axis is responsible for basically switching on the metabolic processes of your body. So if you have too much thyroid hormone, everything is just a little bit switched on. Everything keeps, you're metabolizing everything. You've got, your body is basically prepared to digest, it's prepared to run, it's prepared to fight, it's prepared to do everything. So you just have increased sympathetic activity. The problem with that is that if you are in this constant high stress state, you will have increased oxygen consumption. And if you are frail, unable to cope, you will then tip into high output failure. Investigations, high T4-3, low TSH. This is a little slide about what it might look like. So our patient came in with a trigger, which is the MAB. But other triggers is if they already have known hyperthyroidism and they have a stress event, they will tip into a crisis. Women, if they're pregnant, they can go into crisis. So check the beta HCG, even if they tell you they're pregnant, should be doing that anyway. Other drugs, iodine, amiodarone, salicylates, immune therapy. And as I said, the problem with thyroid storms is that you do go into high output failure, pulmonary edema, high output cardiac failure, arrhythmias, typically AF, delirium, psychosis, and pyrexia. And pyrexia again contributes to that high demand on the organ. General and specific measures in treating thyroid toxic storms. Fluid resuscitation, because that high sweat, high insensible losses, probably to a lesser degree than the other conditions that we've talked about today. Rate control. I don't know why the guidelines say propranolol or diltiazem, but they do, and I will probably follow them for thyrotoxicosis. Probably don't want to wait for my 2.5 milligrams of bisoprolol to work. Having said that, would I sort of stand there with a bit of Besmalol if I was sort of like desperate enough? Probably, if I had a monitor. Cool them, avoid salicylates. I'm not entirely sure why, but it's there, so I'm sure I got it from a sensible source. Sedatives, you're probably very likely to need sedatives if they are very hot and very distressed, and how else are you going to manage them? Respiratory support, if they are in so much respiratory distress because of all of the other problems. Treat the underlying cause. In this lady, it would be stopping the immunotherapy. So this is the very specific slide which I haven't been able to commit to memory because I just haven't seen enough of these. So I would open a book and I would look at the guidelines every time. Specific anti-thyroid treatments, carbimazole, propylthiouracil, I learned to say that before my exams, to sort of reduce the thyroid hormone production. Methimazole is the IV preparation. There isn't a pharmacist in the room, they might be in the office. I need to ask them if we actually have that here. So, because otherwise, what are you going to do if your patient cannot have it, PR or PO? Steroids, don't forget steroids. I often sort of like when someone just asks me off beat, I forget that you have to give them corticosteroids as well. The reason being that the thyroid axis and the cortisol axis interact, whereby your cortisol causes conversion of your thyroid hormone from one form to the active form. Hence, if you do have thyrotoxic, if you have too much thyroid hormone, then if you give them cortisol, it reduces that sort of excessive conversion. Legal iodine, I don't know why, but it's there. So going back to this case, so this is an ICU case. So what happened to this lady? She had a normal inflammatory markers, and we said very early on that one of our differentials, very, very early differentials, is neutropenic sepsis or sepsis from immunodeficiency. But her inflammatory markers were normal to begin with. However, you treat the thyroid storm. What happened next? And then because she was so hemocompromised from the AF, she had some shocks and they didn't really work because the pathological process was there. She was thyrotoxic. All the shocks in the world wasn't going to get her out of AF until we calmed down the thyroid storm. She was 60. She had other sort of issues, or the past medical history. She was tubed. Unfortunately, just because of she is immunocompromised from the cancer, she then got a pneumonia, just deteriorated, and she eventually died. But not of the thyrotoxicosis because we got on top of that. Recap, hour and 8 minutes I've talked for, almost. We've talked about 5 conditions that basically are plucked from Joe's logbook. But the take-home messages that I want you to have is that I don't know whether I tried, but I don't know whether I've succeeded. That crises don't always come with a label. So some of them do. The DKAs tend to come with a label. I would argue that that last case with the thyrotoxicosis did not come with a label. Actually, the differentials are so wide, but actually remember that when you have lots of nebulous problems, adrenal crisis is another one. They don't always come with a label, and they will just come with all sorts of derangements. And if you've got very multi-system derangements, think, is there an endocrine problem? The second one I think was more obvious, or I hope it was more obvious, that crises don't present in isolation. DKA, they can also have war-halves. They come in with thyrotoxic storm, they die of pneumonia. Supportive and condition-specific treatment, and I say that because, for example, the thyroid case, you can shock them, you can shock the AF all you like, but actually what they needed was anti-thyroid treatment. The calcium lady, you can give the calcium, but actually they can't go home until you replace their vitamin D because they can't keep taking standard cal forever. You've taken their parathyroid, what they need is vitamin D. and look for an underlying cause. All of the patients that I've talked about have an underlying cause, and actually, even if you support the endocrine condition, if you don't treat the underlying cause, your patient won't get better. References. Thank you for bearing with me. Any questions? Definitely silence. Thanks, guys. Thank you.